Welcome to the Deep Dive, your shortcut to being well-informed. Today, we're embarking on a pretty fascinating deep dive. There's a new clinical practice guideline just approved last May by the American Thoracic Society.
That's right. All about community-acquired pneumonia, CAP, in adults.
Exactly. And it feels like a bit of a game changer, really pushing towards, truly personalized care based on the latest evidence.
It really is. The whole landscape seems to be shifting.
So let's unpack this. Our sources point to, 4 key areas where things are really challenging some long-held ideas.
Absolutely. And what's really striking, I think, is this move away from the old sort of one-size-fits-all approach.
Right, more tailored.
Definitely. So first up, diagnosis. The guideline suggests lung ultrasound, LUS, as an acceptable alternative to a chest X-ray.
Ultrasound instead of an X-ray for pneumonia.
As an alternative, yes.
Yeah.
But, and this is key, only where the right clinical expertise exists.
Okay, so it depends on the clinician having the skills.
Precisely. And it's not just about, say, convenience or less radiation for you, although those are real benefits. It's also this shift towards non-ionizing radiation, point-of-care diagnostics.
Makes sense.
But there's a caveat. The overall evidence quality for how accurate LUS is, it's still considered low.
Interesting. So it's promising tech, but the evidence base is still developing.
Exactly. It kind of highlights this challenge, doesn't it? How we integrate new tools when the data isn't fully robust yet.
Yeah, that tension between innovation and solid proof.
Okay, so speaking of evolving evidence, here's where it gets really interesting for me. What about when someone with CAP tests positive for a virus, like flu or RSV? Do they still get antibiotics? Because historically, that was often standard, right?
It often was, yeah. And this raises a really critical question because, antibiotics don't work on viruses. We know that.
Right.
So for outpatients, people treated at home who don't have other health issues, comorbidities, the guideline now suggests not giving empiric antibiotics. Empiric meaning the sort of best guess antibiotics before all the results are back.
Exactly. But for outpatients who do have those comorbidities, or for any inpatients, the suggestion is still to go ahead with antibiotics.
Why the difference?
It comes down to this persistent concern about bacterial viral co-infection. You might have both.
Ah, okay.
So it's this really tricky balance, avoiding antibiotic harms, gut issues, resistance versus the risk of missing a serious bacterial infection hiding behind the virus.
Which could be really bad.
Potentially very severe outcomes, yes. And again, it's worth noting this guidance, also based on very low quality evidence.
Wow. So it really underscores the need for that individual assessment, talking it through with your doctor.
Absolutely. Your specific situation, your risks, that's paramount.
Okay, so that viral co-infection advice, that definitely challenges old habits. Does that same thinking apply to how long we use antibiotics for CAP? Because I always thought longer was better.
Yeah, that was the conventional wisdom for a long time. But connecting this to the bigger picture, there's a very clear shift towards, brevity. Shorter courses.
How short?
For stable outpatients and also for inpatients with non-severe CAP, the guideline now suggests less than 5 days of antibiotics, minimum of 3 days.
Less than 5 days. That feels like a big change.
It is significant. And it's driven by evidence showing shorter courses are just as effective for uncomplicated cases.
And presumably fewer side effects.
Exactly. Fewer side effects like C. difficile infection, C. diff, which can be a really serious gut problem linked to antibiotics. Plus, it helps combat the huge public health issue of antibiotic resistance.
That C. diff point is huge. Anyone who's dealt with that knows it's not trivial. So this isn't just academic. It affects patient comfort, safety.
Absolutely. Real-world impact. Now, for severe CAP, the recommendation is still 5 or more days because the risks are higher. It really demands a daily check-in on your clinical stability. Are you getting better? Can we stop?
Constant reevaluation. Got it. Okay, 4th area, corticosteroids, the anti-inflammatory drugs. What's the thinking there?
Well, this area has seen a pretty significant reversal, actually.
Oh, how so?
For inpatients with non-severe CAP, the guideline now strongly recommends against giving systemic corticosteroids.
Recommends against. Why the change?
Basically, to avoid potential harms like hyperglycemia, high blood sugar, when there doesn't seem to be a clear benefit in those non-severe cases.
Okay, avoid the risk if there's no proven upside.
Precisely. But for severe CIP, there is a suggestion to administer them. The evidence there points towards a possible mortality benefit, a reduction in the risk of dying.
Ah, so different calculation for severe cases.
Right. Though, importantly, this excludes severe CIP caused by influenza. The data suggests steroids might be harmful with flu, so that's a key exception.
Wow, okay. Lots of nuances there depending on severity and even the cause. So, taking all this in, what's the big picture message for you, our listener? It really sounds like CIP treatment is becoming much more bespoke, I suppose, less of a fixed recipe.
That's a great way to put it. It's far more nuanced, more personalized, moving away from that rigid blanket approach. And the key takeaway, I think, is this. Medical guidelines are living documents. They evolve. And as we've seen, sometimes the recommendations are based on evidence that's, well, not as strong as we'd like.
Which makes those conversations so important.
Exactly. Really highlights that personalized medical decisions, having open conversations with your clinician about these uncertainties, and really considering your individual values and preferences. That's more crucial than ever. It's about shared decision-making in the face of evolving knowledge.
A truly individual journey in medicine. Which kind of makes you wonder, doesn't it? What other long-held medical beliefs, maybe even things we take for granted, might be due for a similar deep dive, a complete rethink, especially when we look closely at the quality of the evidence underneath. We'll leave you with that provocative thought.